Hi everyone, and welcome to this UCL Minds lunch hour lecture. We're really happy that you could all come today. I'm Professor Christina Pargle. I'm Director of the UCL Clinical Operational Research Unit, and I'm also a member of the independent SAGE group of scientists providing perspective on the UK's COVID response. So today I'm really delighted that we have Oksana Pyzik giving today's lecture. She is a global health advisor, founder of UCL Fight the Fakes, and lecturer at the UCL School of Pharmacy. And she's going to talk about her work and give the kind of global COVID perspective. So specifically, she'll be talking about COVID across the world, misinformation, disinformation, shortages ranging from vaccines to PPE and how they all kind of feed in together. And before I hand over to Oksana, she thought it would be really helpful if I just started with a brief, like 5-10 minute overview of where we are with COVID in the UK, and then I'll pass straight over to her for the main talk. You know, we are now about 2 months into the most recent lockdown in the UK. It has been very effective, and you can see that new confirmed cases have fallen dramatically since their January peak. And we're now at levels that we last saw kind of beginning of October last year. And the number of people in hospital, this is English data, has also thankfully fallen dramatically. You can see now we're still at over 10,000 people in hospital with COVID. That's still a really high number. You can see here just quite how much worse this most recent wave has been compared to the first wave in April, but that is now falling, and hopefully it will keep falling for some time now. But we are still, as you can see, way above where we were in the summer. Deaths, this is the deaths with COVID on the death certificate registered in the UK nations from ONS and equivalent data across the nations. And again, deaths are now steadily coming down. The latest figures were reduced today, and they're at about 2,500, so somewhere around here. So that is also going to continue. Hopefully that will increase even faster than cases with the vaccination program that's been going so well. And speaking of that, over 30% of the adult population in each nation has now received one dose of vaccine. I think actually recent data suggests that in some areas that's even up to 45%. This is really good news. However, that's kind of the overall picture. We had absolutely terrible first wave and a much, much worse second wave, which we're now coming out of, and we are doing really well with vaccination, but it has been quite an uneven pandemic in terms of its impact in the UK, and I just want to say a little bit more about that now. If we look by deprivation, this is English data, then we can see that there's a real clear deprivation gradient, that people in the most deprived areas are much, much more likely to have had COVID. So 280 cases per 100,000 per week average, compared to 180 for the least deprived areas. And not just are people in more deprived areas more likely to get COVID, when they get COVID, they're also more likely to get very sick from it. So this is people in intensive care over the pandemic. And again, you can see this is even disproportionately more than cases. The more deprived you are, the more likely you are to need ICU. The UCL runs a virus watch research study, which is providing really, really important information. And they just released a report a couple of weeks ago saying that, our data shows that people during lockdown, people in more deprived areas were more likely to leave their households to travel to work in shared cars or on public transport than people in wealthier areas. And that's kind of one of the reasons why we see higher case rates in more deprived areas. People are working outside the home. They have to take public transport when they work outside the home. And they're also more likely to live in overcrowded housing. And that makes it a more exposed communities. The other issue is that people can't afford to self-isolate. If they test positive or they're a contact of someone who tests positive, then if they can't earn enough to feed, if they don't get sick pay, then they have to go to work. And that means, again, that their co-workers and their communities and their families are more exposed, as people cannot isolate and protect their communities if they have COVID. And the fact with self-isolation, because it's a legal requirement that comes with quite a large fine, a lot of low-income workers are too scared to get tested if they get symptoms because they're scared of losing wages. And this is from the head of Test and Trace herself who said this. And in the Liverpool mass testing pilot, we saw that only 4% of people in the poorest areas were actually coming forward for testing, because there's nothing they can do if they test positive. So why would you do it? So this is a thing that's kind of hindered the ability to get cases really low in deprived communities. Housing also has a massive impact on health inequalities, and has had a massive impact on COVID. There's a lot of research, including the UCL Virus Watch, that shows that people in multi-occupancy households are more likely to get COVID. And there's also unequal access to high quality green spaces. And as we open up now and open up outdoor spaces in the summer, this becomes more important. If you don't have access to those places, not only is it bad for your mental health, it also means that you might then be meeting people in less safe spaces indoors, again, creating places where it can transmit. And you can see this kind of regional impact. This is just positivity rates by English regions, but you can see there's a cluster that have higher rates, it's the North and the Midlands, and then lower rates in London, the East and the South. And if we just look at these regions by how many of their neighbourhoods are more deprived, you can see that there is this clear deprivation gradient where the North East and North West and Yorkshire and the Midlands are more deprived than the south of the country. And we're seeing that in this kind of persistent north-south divide that we saw in the autumn, and that we're probably going to see again this summer, unfortunately. The vaccine rollout also has a deprivation gradient. This is first dose coverage by deprivation for 70 to 79-year-olds in England. And again, the more deprived you are, the less likely you are to get the vaccine. Now, vaccine uptake is still really high, but there is this gradient. But we also know that for vaccine uptake, deprivation is less of an impact than being from a minority ethnic community. So looking at different ethnicities, you can see there's this really big gradient here where out of 70 to 79-year-olds, 94% of white people had had their first dose compared to only 64% of Black British people. So again, this is going to be an issue going forward. It's just going to exacerbate existing inequalities. And this could also explain why London is actually lagging behind all the other regions in vaccine coverage. So just my last slide. BBC asked a couple of weeks ago whether COVID is at risk of becoming a disease of the poor as we now try and vaccinate our way out of the pandemic. And I think it is. I think it is very likely that will happen, as it did happen with TB in the West as well. And this isn't just a national issue, this is an international issue. And with that, I will stop and pass over to Oksana.
Well, first of all, I want to extend a huge thank you to Professor Pyzik, who agreed to set the scene for us by starting off with what the picture looks like in the UK. Christina has been a familiar face to many who are probably watching because she's been part of Independent Sage and has been doing weekly updates on interpreting various policies and breaking that down for all of us. So it's just such a pleasure to have you as the chair of today's session. So I'm a pharmacist, but I'm a pharmacist working in the area of global health. And I'm based at the UCL School of Pharmacy. And in about 2015, I launched an educational open course, which focused specifically on global citizenship, this concept within outbreaks, and also advising various NGOs as a global health advisor. So that's a bit about my background and where my interests are, which are connected to more of the global picture and some of those inconvenient truths that health in one country affects not only our neighboring countries, but all countries. This sceptered isle is not a natural fortress against infection in the era of globalization. And again, it is, in this instance, I think, particularly important for us to zoom out because we have had some very good news. The vaccine rollout has been enormously successful in the UK. And this follows, of course, the UK having one of the highest mortality rates per capita. But the weather's improving, spirits are improving, and to some, it may seem that that this is all over. Fortunately, this overused phrase that the virus has no borders, which Boris Johnson has himself referenced, while not actually doing a great job of taking care of our borders, From that perspective, we're going to have to start paying more attention to what's going on in other countries. So let's take a quick look at the global overview here. And this is data provided by the WHO. We are still in the acute phase of the pandemic. And for the first time in 7 weeks last week, the number of reported cases of COVID globally began to actually rise. And this follows against the trend of declining cases. So it's plateauing out. And it's brought us up to the cumulative level of 116 million cases and 2.6 million deaths since the start of the pandemic. And on the 11th, it will mark the day that the WHO actually announced and characterized that COVID-19 fit within the term pandemic. That in itself is quite a loose term. The more important date is actually back in January when the WHO had rung the bell saying that this is a public health emergency of international concern. That's the highest level under international health law and regulations. So in the past week, the 5 countries that have reported the highest number of new cases have been the US, and but there are overall, we do see that there has been again a declining trend, which seems to be slowing down, an overall 2% decrease in new cases. Brazil, on the other hand, is on fire. We have an 18% increase. France, also a 14% increase, and Italy, 32% increase. India, again, at 21. So I would very much emphasize here that at a global level, it would be premature and unrealistic to think that we're going to be finished with this virus by the end of the year. I think probably we can get the hospitalizations down, we can get the deaths down and the tragedies associated with the pandemic. But globally, particularly due to specific reasons such as access to vaccines, et cetera, that again, we're still in the acute phase, and we have to kind of separate this mentality that we're in control of the virus. Right now, to quote Mike Ryan of the WHO, the virus is very much in control. And in this instance, again, this means that we still do need to rely on these foundational basic public health measures. These are the things that we have been hearing every day since the beginning of lockdown here in the UK on ensuring that we are keeping our distance, et cetera. So again, variants of concern are being monitored by the WHO. In June of 2020, the WHO did set up a virus evolution working group to specifically track that. We know that, of course, all viruses mutate and not everything that comes up, particularly, for instance, there were some sensationalist headlines around a new variant in LA or California, which again, actually wasn't the case. So the WHO has worked to provide a more specific level of terminology so that we really just focus on the variants of concern. And so that takes us into Brazil, where we do have a variant of concern, P1. This has been a violent upsurge with the biggest numbers in Brazil. And some of the early data actually shows that P1 can be as much as twice as more transmissible than other strains, evading natural immunity. But the vaccines appear to still have some protective effects. So the key goal here is going to be ensure that those vaccines get there. Reinfection is thought to be perhaps linked to this huge resurgence, and there have been cases where people who have had the original strain 6 months later were reinfected. And again, some of the Brazilian researchers estimate that in 100 people who were infected with the non-P1 lineage, somewhere between 25 to 61 of them could have been reinfected. So this issue about reinfection really needs to be better understood for us to engage with the threat level that poses. More than 260,000 people have lost their lives in Brazil, so it has the second highest in the world behind the US. But if we rank that in per capita terms, it's actually 22nd, so behind some of those European nations. Now, Brazil has also been in the headlines a lot in the media due to the Bolsonaro's approach, which has been essentially almost no public health restrictions. And this, again, has also led to the very tragic oxygen crisis that dominated the headlines last month, where patients were essentially left to fend to themselves, crossing Venezuelan borders to try and fill oxygen tanks for their loved ones. So it's been a huge humanitarian crisis in Brazil. And due to the fact that the transmission rates were not controlled by any existing methods, as we see in other countries, that they were not discouraged right from the top. The health minister was booted out of the government when he tried to encourage some of the WHO guidance. And as a result, it's not totally surprising that we see this P1 variant emerge. As we have heard over and over from the WHO, the more that we allow uncontrolled transmission, the more likely for these variants of concern to actually emerge. And that's exactly what happened in this state. It's a case study in which and very few or almost no restrictions at all were introduced. And Bolsonaro earned himself the title by many of his critics as a bozo for that reason. So currently, 3.8% of the population is vaccinated. And the real hope here is that there's going to be, again, that the delay in the rollout will soon ease so that more people can become protected. But if that doesn't occur, we could see even a further variant emerge from Brazil, and one that could potentially be vaccine resistant. And although some people have received criticism for highlighting this threat as scary and etc., we should really have, by this point in the game, not learned not to underestimate the virus and the dangers that brings. So it's better to be prepared for the worst case scenario and understand, where the threats lie globally. So as a result, what does this sort of mean for the UK and how to stay ahead of the virus? We're now still in our third lockdown. So I think it's safe to say that we've been 3 steps or more behind the virus at almost every stage of the pandemic. So although we now have good news about the effectiveness of the vaccines against some of these variants, further research really is needed. And so right now, plugging leaky borders, doing more around quarantine. Christina highlighted that people who are in quarantine really do need to be supported. The hotel measures should not just be fixated on those that are coming from red zones. And we still have problems with test and trace. I think, again, in the UK, we should have a better understanding of the global threats that are on our shores and can leak in as a result. The WHO discourages vaccine passports because it can create inequalities and inequities amongst countries that have vaccines and those who don't. So for that reason, we need to accelerate vaccine manufacturing and rollout globally. And I'll touch on that a bit more later, and that we shouldn't quit the public health measures too soon. And even if in May we're allowed to travel, really being careful about that as well. Also, the UK has been leading in genomic sequencing, but the rest of the world, there are many blind spots. So we need to increase that capacity globally as well. And the WHO has been calling for that. In the US, this is perhaps, again, one of the countries where the virus has become the most politicized. However, there availability of Johnson & Johnson vaccine, meaning that there's 100 million extra doses that can be available by summertime, has led to, I'd say, a bit more emboldened approach in terms of lifting physical distancing restrictions and use of face masks for vaccinated populations. I think that'll be interesting to see how that affects pressures on the current UK government, because we do have quite high vaccination rates. Again, I think the US will catch up and probably overtake the UK soon in terms of vaccination rates. But if we compare also the number of deaths, more Americans have died from COVID than World War I, World War II, and the Vietnam War combined. Yet despite in the face of this tragedy and this very sad milestone of deaths that we've seen, over 500,000, there is also a strong resistance towards public health measures. And here we have images of children burning face masks, hashtag free Idaho. Again, I think that is a cause for concern, because this is almost, you can if the vaccines work, that's an easy solution for the virus. You can compare this type of mentality as an ideological virus, and that is going to be much harder to eradicate in a way. And just simply putting information out there, facts about vaccines, we know hasn't worked. What the WHO again has worked with the Facebook and big tech to try and flag and take down obvious blatant misinformation, but it's a whack-a-mole problem. As soon as that comes up, more comes up. You take one down, it appears in another platform. Again, just highlighting that I do think that there is an over-reliance here about the vaccine doing all the heavy lifting. And I'd be really interested, I think at the end, Christina will be able to comment more on specifically the American situation. But one of the key elements for, I think, pushing ahead is that pharmacies are playing a big role as a vaccination site and hub, and that has been key towards Biden's 100-day plan to vaccinate 100 million Americans within that period. But lots of problems here as well. Now, if we take a look at Our World in Data, which is a website I encourage people to take a look at, it has a really fun representation of the data. We see that Israel is leading the charts. Interestingly, this is, again, daily doses, so I'll show you cumulative doses next. Serbia is doing very well because it's actually opened up its vaccine portfolio beyond the ones that we have used in other high-income countries. So they've are also using Chinese vaccines in their own population, and that's really helped them stay ahead of other European nations. UAE is interesting because although, again, if I go to the cumulative doses, we see it's second in terms of cumulative doses administered after Israel's lead. But because it has less public health measures, we're seeing more problems, health problems associated with it. And Israel has managed to vaccinate its young population, which means that lifting restrictions is going to be much safer than in the UK and the US, which are charging ahead with those strategies. Again, one of the messages that I think on vaccine nationalism seems to have fallen on deaf ears within high-income countries is that we can actually end the global pandemic sooner through vaccine equity. What does that mean? It means that we currently have 75% of all vaccines administered in just 10 high-income countries. And if we go back to even just in January 2021, that meant that there were almost a handful of people who actually received those doses. Now that's through the COVAX facility, which is led by WHO, Gavi, and CEPI, and it is coordinating, ensuring not only the financing, but delivery of these vaccines in low and middle income countries. But part of the problem, which again, I think has not been widely discussed enough, is the barriers around scaling up vaccine production itself. So we've heard a lot about the vaccine shortage, that we can't make that many to vaccinate the world. There's a shortage. We're not going to be able to meet that demand. But a part of that problem is also the trade barriers that are also there. And we've heard from the World Health Organization Director General, Dr. Tedros, pleading with the international community to say that we are in the brink of a moral catastrophic failure, where the price of that failure is paid for with lives and the livelihoods of the world's poorest countries. And he has challenged high-income countries to share their vaccines. Excuse me, I just need a little sip of water. wouldn't be a COVID talk without a little bit of coughing involved. So, yes, so this partly is about the fact that we do have the capacity, if willing, for other countries to support in making these vaccines. That could be achieved through technology transfer. It could be achieved through voluntary licensing, and it could be achieved through temporary intellectual property waiver. And there is already provisions for this in times of crisis within the TRIPS agreement that is the World Trade Organization, essentially, which governs IP laws, etc. So if we can't use those provisions that allow for an IP waiver now, where we have a crisis, a public health crisis that is, the worst in a century, 1 in 100 years type of event, then when is the right time? We really, again, Dr. Tater's used extremely strong language, challenging the UN Security Council to vote in favor of rights and equity, particularly because although all these countries made pledges at the G7, the G20 meetings on rights and equity, the practical solutions, how to actually get there is what's been missing. And so ensuring that we are able to, and other manufacturers help in making these vaccines and scaling them up globally at a much faster rate is one solution. Now, again, this is one where I think there has been extreme resistance to this idea from pharmaceutical industries. Usually the argument used is around R&D incentivization, et cetera. But there is precedent for this, and there is a choice. And there are other ways to also reward companies for this work and partnering with other countries. But the next... many people have forgotten all about polio and the fact that this was one vaccine where the patent was scrapped and it was not made for profit. And Jonas Salk, who created the first version of the polio vaccine, later Albert Sabin created a different one, which is now the one that is used worldwide, but also with no patent and at no cost. And when asked about it, the scientist said, there is no patent. Could you patent the sun? And this, I think, value of the public good and our obligation towards that and all of the consequences that come with it, financial, et cetera, is perhaps not being brought to the forefront in our public discussions. Polio, again, many people don't remember what the iron lung is or have any idea how debilitating this disease was. I think it was really helpful at that time that FDR, the US president at the time, ended up contracting polio during his presidency in order to spearhead research and development, really prioritize that. In this instance, Boris did get coronavirus and thankfully recovered. And the nurses were rewarded with a 1% pay rise for that, rather than a vaccine for the people. So I think that, again, if we look at some of the other options in terms of ending the pandemic sooner, there can be financial models to support that and ensure that the R&D aspect of this vaccine race is still encouraged. And I bring up AstraZeneca as a perfect example of a vaccine that was developed at very low cost, at almost no profit, and has also been referred to as a vaccine for the world. I think the next natural step is to ensure others, low and middle income countries, can manufacture those vaccines for themselves. And some estimate that by giving up that patent, Salk would have been $5 billion worth richer, et cetera. But that is, again, a sort of rough calculation. So thinking about some lessons that I'd like to also bring in is that we really do need a interdisciplinary input in terms of all the ways that this pandemic has affected society. And I have come across many people saying, well, why is a psychologist talking about COVID? They're not a virologist. What does this have to do with the issue. And in fact, there are many, particularly around adherence towards physical distancing, wearing a face mask. I mean, the list goes on. But I think the understanding of that perhaps has been limited. Putting my pharmacy hat on, and for all of the audience who are within the profession, that has been underrepresented at the number 10 COVID briefings. And despite the fact that pharmacies were open during that first wave when GP surgeries were closed, and we're a lifeline to those communities. In England, for instance, there are 11,400 pharmacies, and up to 1,000 pharmacies are currently vaccinating. We should be following the American model to upscale that and get those vaccines rolled out even faster. I mean, we're doing a great job, but I think there's still potential here to improve if we leverage existing public health infrastructure, such as pharmacies. And this would be following in Biden's plan. And also looking at upskilling some of our workforce. So in US and Canada, we also see that medical students, pharmacy students are pitching in vaccinating healthcare workers. Another important point is long COVID. And again, thinking about primary care being more of a point for support and monitoring for us to really understand the long-lasting impact. We've had some really worrying reports about associations of stillbirths and COVID coming out of Ireland that will need further investigation. But it is also another reason why we should try to drive out COVID as much as we can. Another part of fighting the pandemic, and although I hesitate to use the war analogies too much, but we are really fighting it on multiple fronts, including the digital frontier. And the infodemic in many ways is much harder to tackle than the actual virus itself, which science has really done a phenomenal, the scientists themselves have done a phenomenal job in turning around a record of a new vaccine, and I think deserving ultimately of Nobel Prizes as well. And women in science, given that we've had International Women's Day just yesterday, particularly leading the front on that. Historically, we see that the problem with misinformation and the opportunity for criminals to exploit fear does occur at times of crisis. So we only have to go back to plague in the 17th century in London with the quackery running rampant, cures being peddled. In Iran, 44 people died after consuming what ended up being toxic ethanol solution. And this was via information they got from Facebook and other people profiting from misinformation. In World War II, we also saw post-World War II an antibiotic shortage, which led to low-quality antibiotics. People were diluting them again for profit, and equally falsified medicines for Ebola over the course of the 42 outbreaks that have been recorded to date. Even before the vaccines were approved, shockingly, we saw that they were being distributed in Israel and Uganda, and then post the authorization in various countries, they started to pop up in the UK, China, and South Africa. You might have seen the BBC story in which a 92-year-old woman in Surbiton actually received a fake COVID vaccine where a worker posing as a health worker came into her home and vaccinated her for 150 pounds. Not the most clever criminal strategy, because you can't do that at scale, but put that on the dark web and you will be looking to make big money that way. And certainly the UNODC has projected that many organized criminal groups have actually shifted their focus away from their usual focus, which could be arms, etc., and have focused on the current COVID crisis. And that's also been linked to fake PPE, particularly in the first half of the pandemic before vaccines were available. And a lot of this online. So cybercrime has increased by 5 times. And equally, when former US President Donald Trump had hyped up chloroquine, hydroxychloroquine, shortly after the WHO issued an alert that there were falsified versions of these drugs in 300 hospitals and pharmacies in the DRC, Cameroon, Burkina Faso, and even in France. So again, it really follows what is in fashion, if you want to put it that way, what the particular products that will be targeted. Again, the dark web, suspicious website, 4,500 new web domains, including keywords for COVID-19, corona vaccine, and cure COVID. And a problem with this is the fact that some surveys have found that 44% of US adults feel that they do not know enough about science to understand finding in the news. Pair that with fake websites, then selling fake products. And many of you who are listening today, I'd be curious to know, do you know how to verify an online pharmacy? So if you wanted to, other than name recognition, could you identify fake boots? Could you identify an independent fake website which is operating illegally, claiming to be a legitimate website? This is another blind spot for the public. So before the pandemic, there were 1 in 10 medicines worldwide were either substandard or falsified. You may know this as counterfeit, but that got removed because it focused too much on trade infringements, and really this is more of a public health issues. And that number is an estimate in low and middle income countries, but is much higher in certain regions. So even in and depending on the medicines themselves, so in much higher rates, for instance, in Malawi, et cetera. We expect this to also rise to even higher rates post-pandemic, although that data is not yet available. Prior again to the pandemic, the medicines that were most targeted were antimalarials and anti-infectives. But it could be a whole range of medicine, everything including up to paracetamol that's available over the counter. Interpol has recently dismantled a network where it seized 3,000 doses of COVID vaccines from Chinese factories, 2,400 doses seized in South Africa. And the Interpol chief claims this is just the tip of the iceberg because this is all that they found. It's very hard to actually be able to track this all. And even within the first week of the WHO last March, announcing the pandemic, 14 million worth of counterfeit products were seized by Interpol, mostly around fake PPE and sprays. The FDA also issued thousands of warning letters to companies in the US that made false claims and cures and treatments. So again, this particularly due to the rise of social media as a news source and as a marketplace to purchase things, means that this is one aspect that I think is being highly ignored within the public health community. So just to wrap up and think about some of the things that we got wrong, and this list is absolutely not extensive. It's what I could get on one slide, and I'm sure Christina can add on to it. But early on, and this is not just the UK, some of it is specific to the UK, but it's also the lack of available data and what then informed the WHO guidance. So we believe that it was mostly symptomatic, and we underestimated the extent of asymptomatic transmission. And for that result, it was for that reason we did see that mass events went ahead, including the Cheltenham Festival in the UK. We also didn't get right the preventative value of face masks and the level that aerosols play in how long they can linger in the air. It was viewed as something that would really only be a threat to healthcare workers who are doing intubations and other airway suctioning type procedures that generate aerosols. But we now know that due to some of the studies done even in Australia within the quarantine hotels, how actually they can linger in unventilated spaces. The ventilation aspect is still, I think, not being prioritized enough, discussed enough, particularly because it's very difficult in some aspects to upgrade every home and every workplace to do so. So we only have methods like opening windows and doors. It's better than nothing, but we need to be encouraging that. again, late to lockdown, following the flu model versus the SARS in the sense that it wouldn't make sense to test and trace because we'd be too overwhelmed. Meanwhile, there was a long enough incubation period for those interventions, such as isolation and quarantine, to be useful, unlike in flu situations. And also the preemptive decision that everyone would get fed up with it and be tired of restriction fatigue, so let's not bother. The very obvious pursuit of herd immunity, which we heard from Patrick Vallance around, it would not be desirable to prevent infections, which was later backtracked and denied, but that we know naturally without vaccination, there are almost no diseases which were overcome without public health measures or some form of vaccination. So for instance, like yellow fever, would be one example, along with many others, MMR, et cetera. Still track and trace. Again, if you are a fan of the Independent Sage weekly briefings, you'll be hearing a lot about this anyways, and how this was just completely disconnected from the integration of public health hubs, yet one of the most expensive aspects of the entire COVID response. And I don't feel that lesson has been learned or any accountability held toward it. Slow to implement travel restrictions. We're still on the weak side for that compared to many countries. We don't have the strictest borders control in the country. I think that's a fact check. And again, this sort of art of acting on imperfect data versus delaying action. I think Christina did an amazing job of highlighting some of the BAME inequalities and how this has not been addressed enough in our policies. The famous Eat Out to Help Out scheme, which let's see if that gets rolled out this summer. And overall, the form of leadership and communication, which I will not expand on further due to interest of time, and that could be a lecture in itself, but mixed messaging really being the aspect of it. And that's not to say that science doesn't change, but there is still a way to do it would be much more clear than what we've witnessed. I would like to say some positive things to balance that off, including that there was furlough available, but we do need more of that to support individuals who have been out of work. The vaccine rollout, which was the JCVI led by Kate Bingham, again, excellent procurement strategies, really leveraging those networks. Supply chain dependencies that existed were then reshifted so that there could be more local manufacturing. The UK is leading on genomic sequencing and is the highest donor to COVAX alongside the US globally. Now that's in funds. It doesn't mean that the money translates immediately into jabs and arms. So some of that could be vaccines as well. And the fact that the UK developed the most affordable vaccine, I think, is a point to celebrate. And we also piloted the trials on the successful use of dexamethasone. There was a lot of concern that it could actually exacerbate COVID, but now we find that it is one of the best interventions as well. And other treatments, again, this is not an exhaustive list. So looking forward, I think that what the pandemic has exposed is that our NHS has been under pressure for too long under these austerity measures, and that it needs further funds along with supporting the health workers who hold it up. Further investment in R&D to make an UK attractive biotech sector to get more success in developing these types of medicines, and reimagining global health security version 2.0 so that we actually take on board the pandemic exercises, because we do these types of run-throughs, if that's how you want to call it, but we just sort of ignored what needed to be changed. So really pushing that up in importance from a political perspective, supporting low and middle income countries to develop their own pharmaceutical manufacturing capacities, and 3D printing of vaccines, which I think will be possible in the future. Now, it's not just in the UK. I think the WHO has not gotten everything right as well. They've done the best that they can, given that they have the budget of half of a US mid-sized hospital and have no legal authority to enter countries without invitation of the government. So it definitely needs some re-examination about not only its funding structures, but what ability it has and how we can strengthen international coordination framework and strengthening that response. So a lot that we put in 365 days later, we're still in this acute phase. I hope that we learn from some of the mistakes that were made and that we do enter into a stage of real solidarity with the rest of the world now that we've improved our domestic situation. So I'm going to pass back now to Christina and see if we have any time for some Q&As maybe.
Thank you. That was brilliant. So interesting. It is literally a year to the day that I was last in a crowded pub. And I remember very vividly going March 9th last year to a pub quiz. And at the time it felt quite unsafe. And I thought, well, I won't do this for a while. But I never in a million years thought it would be a year. Well, it would be much more than that by the time that happens again. But anyway, thank you for the talk. So one of the questions we actually got was, could we have been in a different place? Are we doing well? And I actually think, your penultimate slide dealt with that brilliantly. I think, yes, we could have done better. The fact that many other countries did as badly or nearly as badly doesn't mean that that's okay. I think, hopefully every country learns from this kind of pandemic. One of the things you were saying about herd immunity as a strategy, I thought was really interesting. And obviously, Sweden famously went that way. And we were talking about it a year ago in England. But I never quite understood it because it always felt to me that why not try and suppress it? And if things change and there's no prospect of a vaccine, or it turns out you can't do it, or it's too damaging, then you can still go for that strategy. It always felt like to me, why would you not try to suppress first and then reassess where you are, 6 months later? Because obviously the countries that did bet on a vaccine way out, all the places that have achieved suppression have done much, much better, not just in terms of COVID, but in terms of their economies as well.
I think that's absolutely, I think many people are asking that question. And my view on it is that I think that when it is not viewed by a health lens, and of course, these are all intersectional, it's going to impact on each other. But I think it was a bit of arrogance in thinking, well, we can outgame this in the sense that we won't have to damage our economy at all. And or we'll take it without these restrictions and we'll be able to develop this herd immunity and it'll be all over before we know it. And this sense that, you can outgame it, and really prioritizing the economic impact rather than seeing the two are interlinked. So that's, I think, the aspect of it, that, again, not just that, there's nothing we can do now. I think it is also, what are you going to prioritize in making those decisions? And let's not underestimate, the fact that economic consequences have significant tolls as well. But we did poorly on both accounts. We didn't end up suppressing very well. We're in third lockdown, and we have one of the worst economic performances as well. So we lost on both accounts in that situation. There are many examples of countries that went for a more flexible model, but were more aggressive in the beginning. If you don't understand the virus, you don't have that information. It's a big gamble to take.
Yeah.
So I think that's, again, something that is, of course, an immensely difficult decision. But I agree with you that on that particular note.
And I think, I think you made that point earlier, it's still a new virus. We still don't know what the long-term impacts of having COVID are. Particularly in children, there's this kind of narrative evolved that kids are absolutely fine. Well, we don't know that. And there is emerging evidence of long COVID in kids. And we do have to think about when are we going to vaccinate children and all this kind of thing. Anyway, we've got loads of questions, but I want to, someone asks, should the WHO have more authority to perhaps force countries or pharmaceutical companies to provide vaccines for low resource countries? So I know that at the moment, WHO doesn't have that authority. I don't know how it would get that authority.
Well, yes, in that instance, we would have to go back. And I think there has been a major public misunderstanding of how the WHO operates. It's a UN subsidiary agency. famously, the former director general had said, I have 192 bosses. They report to the demands of the country, and they really exist to provide technical advice and expertise to countries. However, if we go back historically, looking at 2003, the SARS event there, we had Brundtland, who was the DG at that time. And because she had been like the former prime minister of Norway, she really had no qualms about calling out the fact that there were some misgivings about the extent of reporting in China at that time. And there were and this was over 20 years ago. So, China is in a very different place now than it was then, but there were a lot of gaps in the public health infrastructure, and an attempt to also cover up and save face in that first SARS crisis. But because, there was that strength in leadership, and in some ways, you would say it wasn't a very diplomatic way of doing it by going directly to the media instead of behind closed doors. But it ended up being in 30 or so countries, and it still had huge economic consequences that people don't fully appreciate, but it didn't get to this scale. And that's not just because of the actions that were taken after that. It also has to do with the fact that it's a different virus. It's much more lethal. People end up very sick. They can't go on to be mass spreaders. The asymptomatic profile here, and the fact that it's actually a less deadly virus, is counterintuitively makes it much more dangerous to people. So I think in that sense, you almost have to reimagine the UN as a whole in order to achieve that. I think that now we still see that there is, particularly because of Trump's response to WHO's leadership, they left, they came back. Absolutely, we need the World Health Organization to be leading on this, but I do think there has to be, and one way would be through funding. There could be some other provisions that would have to be agreed by everybody. The United Nations represents all the countries in the world, so the 26 scientists that penned a letter to say, they're unhappy with the investigation into the Wuhan and the origins of COVID. Well, in that instance, it's, you need Beijing's cooperation on that. And it's really in a study to help us understand where it came from to prevent future outbreaks, rather than not going to get actually a huge amount out of just playing the blame game. Although accountability, of course, is incredibly important. So I don't think that, that letter actually gained much international traction in terms of demanding further action. I think it's really important to understand that, the WHO has limitations, and in order to get what we need, there would be quite substantial changes in international laws that would be required. And if anything, I don't. What we actually need above that is international cooperation, and for countries to be able to work hand in hand with that type of organization. It's only going to encourage more cover-ups if it's too much of a stick approach.
So another question we've had is, how do you rate the Russian and Chinese vaccines? So I guess from my knowledge, the Russian one, Sputnik, which is a really good name for a vaccine, I want to say, they killed that. Seems pretty good. It has pretty good efficacy from what I've seen. I don't think either of the vaccines have been submitted for approval here. And the Chinese vaccine, is it Sinovac or something it's called, doesn't seem to have got as good efficacy as the other vaccines, and also doesn't seem to be that effective against some of the newer variants. But I mean, what's your view?
Well, I think, some protection is better than none. There are many countries, low and middle income countries, that are not getting vaccines from high income countries. As a result, it has actually led towards vaccine diplomacy and a shift in geopolitical alliances as a result. And Russia and China are actually giving out these vaccines as a way to buy allies. And who can blame the countries that don't have access to medicines to get something that at least works on some level, particularly against hospitalization and death, which are the most important metrics to look at. Of course, transmissibility is ideal if we can ensure that it prevents transmission. But I think the Sputnik the reason for the initial major hesitancy around it was more around medical ethics and the fact that they really started rolling out and making announcements and licensing the vaccine before phase 3 had come to an end. And I think that sets a dangerous precedent. But from and right now it is under WHO review. I think that sort of the early data does show that it is a relatively effective vaccine, more so than the Sinovac and Sinopharm. I mean, again, Russia has a long history of brilliant scientists, but maybe a bit more of a in terms of supply chain and integrity and security of that. I would have almost more concerns than often the issues with any of the vaccine itself. I think ensuring that is improved is probably some of the hesitancy that we see from other regulatory bodies. I mean, but the European, the EMA is looking at Sputnik 5 and evaluating its efficacy, but it's just not come to a conclusion yet. So, I certainly can't speak for the EMA on that, but I wouldn't underestimate it either.
Yeah. Another question we've got is, what lessons, if any, can the UK learn from Germany in its pandemic response?
Christine, I believe you're half German, so we're going to have some conversation about that. Well, I think really, I think at the beginning of the pandemic, we had something like 8 public health labs that were authorized, had the appropriate clearance to work with the SARS-CoV-2 virus. And, Germany just from the get-go was in a better position with being able to test and have that expertise on hand. And they were very aggressive in terms of going into communities. They took an active versus passive approach as well to find those hot spots. And they were fast to act. Doesn't mean that it was perfect the whole way. And they did have a resurgence and problems as well. But I think that in terms of the original German response, their sort of technological strength really served them. And the fact that they had that infrastructure investment ahead of time, not waiting for disaster to happen to try to scale things up, and bringing along, local public health. There was a real local approach as well, I think is what led to their initial success. Now, with the vaccine rollout, there are other things that are, I guess, slowing them down because they're operating as a block. But Christina, I mean, I'd be really interested to hear your view on it too.
Yeah, I mean, I think certainly the fact that they scaled up testing and contact tracing from the very beginning when we were scaling it down. So we didn't have testing in the community until May, which is crazy if you think about it. But it didn't help us avoid the second wave. And I think a couple of other things. I think one is that the UK has the lowest sick pay rates, statutory sick pay in Europe. So like in Norwegian countries, in Germany, you get something like 80-90% of your pay if you're off sick, whereas here it's 90 quid a week. You just cannot live on that. So I think that's been a big issue for us in self-isolation. I think the other big thing about Germany is that I think Angela Merkel has actually been an exceptional communicator on COVID throughout. I watched a video of her explaining exponential growth to people in a news conference, and actually kind of saying, if we wait to act until it looks bad, we've missed the boat. And I feel like that's what we've been doing here, consistently trying to, with our government trying to find this middle path. Or I don't want to do kind of incremental measures. And we've learned incremental measures don't work. You either get ahead of it or you're behind it. And I think that kind of communication, explaining the caution, explaining that it's bad. And also, I have heard her occasionally say, we didn't do it this well. We've made mistakes. And I've never heard our government admit to having made a mistake yet. And I actually think that creates mistrust. Mm-hmm. And it also creates an environment where you can't learn, because how can you learn if you never admit to having done anything wrong? So I think that has been quite a big difference. And we've seen that in other leaders, like in New Zealand as well, where having that kind of honest, open approach, understanding the science and explaining the science has been a really powerful thing to get the population behind you as well. And actually, I think you've seen it a bit in Scotland with Nicola Sturgeon as well.
I completely agree. I mean, I think looking back at some of the messaging that came out of top leadership as well, saying at the beginning that test and trace is something that is for poor countries. Just absolutely shocking, and also like not true. So when it comes down to the pandemic handbook, if you want to go to that level, but equally just cringeworthy moments where I shook everybody's hand, and I take it like a
take it on the chin.
Take it on the chin, not the wrist. I got the wrong body part there. But and again, I think some humility in the fact that no country got it 100% right. This idea of appearing weak, being so feared, whereas disastrous consequence. But really, and I think that was on my slides as well. That final, what we got wrong, leadership and communication. It is complex ideas don't have to be dumbed down. They just have to be broken down.
Yeah, exactly.
Again, Angela Merkel, being a scientist, really had strength in that. So, but I think we're probably getting close to time. So
yes, we are at time, and I'm being told to stop it up. But I mean, I could talk about this for hours, so I will stop now and say thank you so much for your talk. It was really, really interesting. Thank you to everyone for joining. You can see upcoming lectures by visiting the UCL Minds webpage. And yeah, everyone stay safe and enjoy the outdoors. Have a good day, everyone.